and diabetes, and obstructive sleep apnea. So we do have a panelist with us, Dr. Devashish Basu, who is the president of DAY, and also we have Dr. Mary De Cruz. She is the vice president of DAY. So before going to the session, I'm going to give a little bit brief for regarding our organization. So what we are doing currently, the third session we're going to currently is going on. There is a certificate course on diabetes educators, so it's CCD. So this course is running from August 2021 and is going to end on Jan 2022. And this is only for day members. Then another course for certificate course for diabetes educators, which is going to happen in March 22. And it is going to end on August 2022. And the course fee for this session is 5,000. And early bird enrollment we do have. There's opportunity to have with us, that is for 3,000 till 31st Jan. You need to enroll. So this again is only for day members. And on a screen we have shared our contact details, so you can get connected with us for this course. The second session, which is going to happen next month onwards, is refresher diet, and we're going to start this on November 2021 and till end in Jan 2022. And the course fees 2,000 and is only for day members is 1,000. And another interesting thing is that today is the last day for registration, and we have only one seat left. Again, we have shared our contact details, so you can connect with us. And the third session, again, refresher course on clinical diet, will start on March 2022 and it will be there till May 2022. All the courses are prefixed monthly twice class, and for this course we have 5 modules, workshop and exit exam. For this course, our course fee is 2,000 and for day members is again 1,000. Registration open till 31st Jan 2022. This is the next session. So now we are going to enter our guest session. So let me introduce Dr. Devashish Basu. He himself doesn't take any introduction. He is the president of Diabetes Awareness and You. And Dr. Devashish Basu is a distinguished consultant physician in Kolkata with much experience and expertise in the field of internal medicine, diabetology, and cardiology. And he has been in this medical profession for over 2 decades in various capacities and at a number of hospitals and other medical institutions and colleges. And his responsibilities have included medical practice, teaching, research, and corporate administration, as well as advisory and social roles. So, Dr. Devashish Basu, over to you for our today's session, that is nicotine and diabetes.
Thank you, Neela, and thank you for saying that it's only 2 decades. So I feel very young. I'm almost touching 60, and I started practice when I was 25. So I think it's almost 35 years. So anyway, that doesn't matter. What matters is what we are doing is right or wrong. So today, as we are here in this meeting called the A to Z, I have just, did I share, can you see the slide?
Yes, we can see.
Which slide do you see?
So you can, no.
Yes. Can you see the slide?
This is diabetes and periodontal.
Can you see the screen?
Yeah, I can see the screen.
What do you see in the screen?
And someone,
Feeding.
Kiran is offering some food to someone, I think.
Who is that someone?
Indrajit.
I think Indrajit,
So Meredith is bang on. So this is how the relationship is. This was, Indrajit and Kiran, perhaps the two most important people in my life, and in fact in my big journey. And they have made so much inroads into the understanding of the meaning of life, either way. But they are obviously the best of brothers and sisters. See the affection, the compassion, in both of them. One accepting the offer, the other sharing from her own food. Now, why I'm showing this is the next slide. So and the next slide you will see Kiran snatching that cigarette from Indrajit's mouth and lips, and tearing it apart and shouting and reprimanding, and Indrajit looking at the other end said, I'll try, I'll give up. So she said, no, you can't do this. This is this is diabetes awareness in you. You can't smoke. Anyway, why I started this journey is because of the two very important people in my life and their contribution in either way. Indrajit has been, of course, the mastermind behind Day, whereas Kiran actually came into our lives and made Day what it looks like today in terms of its publicity and fame. But they are both trying. I will tell you that Indrajit is also trying to quit, and Kiran was also trying to help him in her own way. Now the type, will come directly to the topic. We have understood that this is very important, that smoking can cause an elevated risk of type 2 diabetes. This is the data saying of non-smokers, if we take that as the cutoff of 1. This is Béziot's paper way back, and it was published in France. It had people with almost 12,000 men, more than 12,000 men and 15,000 women. And what they said, that they were looking at the habits, smoking and alcohol, and they found that the odds ratios, as it was expressed in terms of the glucose levels, gradually over the years, there was increase in risk of diabetes, see 1.49 with people smoking. So 50% more chance of having diabetes in people who smoke. This is risk of developing diabetes. That is risk of diabetes. This is risk of developing diabetes. This is even higher. So you see people smoking, say, 10 cigarettes a day will almost touch 1.8. So it's 80% more chance of developing diabetes. This is what happens when you stop smoking. The beauty is, as you go down the ladder and the time since, you stopped smoking, you see your chances of the increased risk of diabetes, or the risk of developing diabetes, is decreasing with longer duration of cessation. And it virtually returns to that of a non-smoker level by 20 years of age of quitting smoking. The pathophysiology associated with hyperglycemia when you're smoking is because of the increase in the free fatty acids that might cause the insulin resistance. This cigarette smoking releases free radicals, we all know, which will reduce any kind of sensitivity for any hormones, especially the insulin sensitivity. The tobacco, we know, stimulates a lot of endorphins and the hormones like epinephrine and norepinephrine. So they cause indirect counter-regulatory mechanism. And finally, there is an direct toxic effect of smoking or nicotine on the pancreatic cells, because you have the N-acetyl choline receptors, which are the nicotine receptors, NI receptors, and it has been seen in rat model, in mice model, in monkeys, and especially in the womb or the fetus of pregnant mothers who had been smoking. The association between smoking and diabetes is that, particularly in diabetes subjects, if you are smoking, it will worsen the metabolic control and it will double the risk of heart attack. So if you are a person with diabetes, your chance of having a heart attack is 4 times, we know. And if you're smoking over and above that, then your chance you're getting a heart attack, that risk becomes 8 times. When you're managing the patient with diabetes with insulin, you are actually needing a much more insulin dose requirement. So that, when you compare with non-smokers, and there is impaired insulin-dependent muscle glycogen synthesis. What happens? What does insulin do? It picks up the glucose and it stores as glycogen. So that is how the sensitivity is talked about. But here, the glycogen synthesis is abnormally poor. People with, who are smokers, especially young, and that is also a similar, scenario in pre-diabetic subjects. Now, I will just briefly touch upon the fact that what are the possible causes. As I said, of course, insulin resistance, insulin sensitivity. There is, these changes in insulin signal transduction. There is enough insulin which is being secreted in your body, but when it is going to the skeletal muscle with the glucose, to get the entry of the glucose into the skeletal muscle, there has to be the GLUT4 receptors coming in, and this, after the tyrosine phosphorylation occurs in the insulin receptor substrate, where it's usually the IRS1. So in the beta subunit, when it attaches, it is not working. And we see the changes also in the transport mechanism. We have other effects of nicotine directly, indirectly, and as I said, the counter-regulatory hormones. The issues are that smoking and diabetes, what are the issues are, people have very high risk of CVD. They can have obviously they have associated hypertension. We know smoking also gives you hypertension. It can cause stroke, MI, myocardial infarction, heart attack, heart failure, and the peripheral vascular disease. So what about diabetic patients who smoke? We see the hazard ratio for coronary artery disease is that it is 41% of them suffer from CAD. As we said, if you're smoking, if you're diabetic, your chance of having a heart attack is 4 times. You're smoking, it is 8 times. This is, these kind of, there have been a lot of studies where people have pumped in high levels of nicotine and seen the blood glucose changes in the human RBCs, and that has shown us in vitro experiments, the blood sugars going high and higher up. And this is, the simple diabetic patients are at risk for retinopathy. Of course, they are. We know hypertension, bad lipids, or the diabetic dyslipidemia, they all adversely affect all the arteries. Diabetes is a vascular disease. So especially the microvascular diseases are also compromised, as we talked about the heart attack. So retinopathy is something that is very, very commonly seen, especially in people with type 1 diabetes who are smoking. There is, of course, a risk of development of cataract in these people because of the oxidation and the precipitation of the lens proteins. The tobacco smoke, the plasma concentration, of the nutrients, when it is important for the lens transparency. You know how we use sorbitol, gets deposited and you get a sunflake lens in diabetes. Similarly, tobacco smoke adds to that, and it causes also other complications. We know diabetic people are actually, if not well controlled, are at high risk of nephropathy. Associated hypertension also affects the vasculature of the kidneys. The lipids also disturb the kidney vasculature. And smoking, it severely affects the whole problem. So we say people who have diabetes and nephropathy, the CKD cases, whatever you do, first and foremost, I mean, obviously, the blood pressure control is just not in your hand. It is a team effort. But what is in your hand is just stop smoking. Because as you see, even in the best of control that you are achieving, and you keep on smoking, your CKD goes on worsening. And that is primarily because of these mesangial cell proliferation happening, the fibronectin production happening, and of course, like environmental tobacco, etc. Basically the ECM, the extracellular matrix proteins, they cause all the damage of the collagens 4, 6, etc. But we know that smoking is associated with neuropathy as well. And we have seen that 2.2 times greater neuropathy is seen in cases of smokers versus non-smokers. And the erectile dysfunction, it is, of course, a very common abnormality that we all know. That also keeps showing up in smokers very badly. So that's an area where we ask the patients to stop smoking, because otherwise we will never improve on the erectile dysfunction score. In neuropathy, we have seen people with doing the EMG test or the NCV test that even despite the A1C improving, if you are still smoking, there is actually no improvement in the neuropathy score, especially people who have severe long-standing chronic painful neuropathy. That has been very strongly associated with just a second. Just a second. Sorry. Just a second. Okay. Actually, there's no. Anyway. So, pregnancy. neuropathy we did, and we were also talking on neuropathy. So I would also like to tell you that, smokers, they die almost a decade younger than non-smokers. And if you really take age as an important consideration in all this multi-regression analysis. So these are the things that we need to keep in mind. We need to understand that whether it's macrovascular, all the Wikipedia studies also showed us that these have very strong effect. And we know that smoking increases the risk of stroke as well. I didn't talk about that. In fact, it has also shown to increase issues of atrial fibrillation, the tachycardia, etc. And so, the embolic stroke happens more with cigarette smoking. But the brain affection is perhaps a little lesser than people with heart the problems. So in smokers who smoke around 1 to 14 cigarettes, less than 15 cigarettes a day, the risk for the coronary heart disease was very significant, but not for perhaps stroke. But in people who smoke more than 15 cigarettes per day, their relative risk for both coronary heart disease and the stroke got increased by the OR was almost 2.6 and 1.8 respectively. So this is something that we need to keep in mind, that the relative risk of smoking, as it is shown higher in MI and the CHD, is actually more for stroke, especially in people with for the 30 to 59 years of age. This is the data on pregnancy, and we know that it has decreased beta cell apoptosis. We have seen that these are the changes which are happening absolutely at the molecular level, where the beta cell proliferation finally does not occur in the offspring. So these are the people who, for mother smokers, they will have perhaps the expression of type 2 diabetes even at an earlier age. Now it is kind of assumed that below the age of 20, these people will show up with diabetes. So if you have a history of mothers smoking, please try to screen these children as early as possible. So now these are the drugs. We know that there are a lot of drugs which have impact on with smoking, especially the antipsychotic drugs, the olanzapine, fluvoxamine, even the asthma drugs. They all, you are smoking, you're actually making your asthma worse, and your theophylline doesn't work. You're even having clopidogrel. Say all our patients, we assume all our diabetes cases have some kind of a heart problem, and maybe a preventive clopidogrel would be helpful. But if you're smoking, then that you talk about PPI, pantoprazole, and other drug interaction with clopidogrel, but you hardly talk about smoking as the impediment. The beta blockers, we really recommend beta blockers in diabetes because of everything, whether it's a heart failure protection, whether it's hypertension protection, because of even neuropathies. So that also has a nicotine-mediated sympathetic action, and we know there is peripheral vasoconstriction happening. So these are the areas where the children, and this is an educator's program, and I believe the best educator should be the doctor himself. So he should also keep this in mind. He should keep in mind that women who are 35 years of age or older, and they're smokers, they and smoking at least 15 cigarettes per day, are at very, very high risk of having any kind of drug interaction, and they are very liable to having all the morbidity like stroke, heart attack, thromboembolism. These are the main types of replacement therapy. I will not because that's maybe that is a job of the educator, if he or she is not a doctor, to recommend, but not to really throw light upon to the patient directly. Once a molecule like bupropion or varenicline is started, then again the role of the educator comes in. He or she has to explain that bupropion may cause accidental suicidal tendencies, or varenicline you might have similar suicidal tendency, maybe having tremendous nausea, etc. So that's the educator's job again. So this is this slide which I want to show to everyone, that whenever whoever a person who's smoking or not smoking, visiting a healthcare professional's clinic, whether you are a doctor or whether you're an educator, a non-physician clinician, like in my clinic, in Meredith's clinic, we all are, surrounded by the bevy of beautiful girls who are actually much more non-physician clinicians, much more strongly active than perhaps both of us. And they make a change. They make a change. 70% of the people will start thinking about the quitting of smoking because when they talk to them or when they're appraised of the the nonsense part of smoking. And if the physician is also at every visit trying to coax or at least very smoothly, gently talk about the importance of smoking cessation, that will help the the public, the general mass. So we know that compliance is the key to quitting. We can suggest a lot of activities, but most important thing, we have educated. In fact, I remember Kiran conducted a program in the Indian Science Congress office. It's almost 7 years back, which was a very strong protagonist meeting, arranging psychoanalysts, psychiatrists, people like us, and of course we wanted also to have motivational speakers. So we need to have motivational interviewing from the patient, and we want to say that if you can have an average 4 to 7 quit attempts before you actually successfully quit tobacco, because once you fail, twice you fail, you don't suffer from the ignominy that you are a failure. You can keep on like those, you keep trying and trying, and finally, definitely on the 8th attempt, I'm sure most of our patients have come out of it. So this is my last slide, and I'm sure that Kiran will come back and Indrajit will be there. So if it is the 7th attempt till date, Kiran will be successful, that Indrajit will give up smoking on her 8th attempt. Thank you, ladies and gentlemen. So I'll stop sharing. I left you at 5:30. Meridhi, I'm on time.
Yes, good evening, doctor. Thank you. How do I make this?
Thank you. Hello. You're on time, sharing for the beautiful presentation. We'll move to our next speaker. Just yes, ma'am, you can share your screen.
Yes. So thank you so much, and it is such an
I think you're on mute.
Oh, okay.
Ma'am, you're on mute.
Is it?
Okay, we can hear you now.
Can you hear me?
Yes, we can hear you now.
Okay, so thank you so much, and it is always such a pleasure to share the screen with Dr. Debashish Basu, President of DAY, and especially on a teaching podium. I'd like to thank Niloy and Shuparna for your help in connecting us across India. I will be speaking on one of the other important topics, and that is obstructive sleep apnea. So we know what is apnea. We often ask our patients a lot of questions in our personal history, and when we are talking to them about their lifestyle measures, we ask about eating, what time they eat, what time they start, how much exercise do they do. But sometimes, and of course, smoking. And now even young girls have started smoking much earlier. In fact, I was the other day walking across a pavement and somebody commented that more girls are buying cigarettes and nicotine products from shops now than before. So sleeping habits, we always ask. We ask about bowel and bladder habits. We do ask about circadian rhythms and how people respond to travel. Of course, now there's not much travel. And then we ask about your partner snoring in bed. So it's usually the spouse who knows best whether the partner is snoring or not. So these are some of the important questions that we ask in history taking. And of course, by definition, Sleep apnea is a cessation of airflow at the nose and the mouth lasting for at least 10 seconds. And it could be obstructive sleep apnea or it could be central apnea. Whenever it is obstructive, the name explains that there is some obstruction in the upper airway path during sleep. So it could be complete or partial obstruction, and the causes could be foremost is obesity, polyps, or enlarged tonsils. And there is varying degrees of oxygen desaturation, hypercarbia, and sleep fragmentation. With the result, person is usually tired and exhausted when they wake up instead of being refreshed after a good night's sleep. Central repeated episodes of apnea causes by temporary loss of respiratory effect during somnolence. So more than 10% of all apneas could be idiopathic presentations. So sleep physiology is very, very important. And it is basically a circadian rhythm. Light acts as the trigger for getting up and for going to sleep. So it is controlled by two oscillators with different period lengths. The first one is the biologic clock governed by the suprachiasmatic nucleus. And the second oscillator is the neurobiological mechanisms. And there is a synchronicity of a 24-hour period in which we sleep, wake, and do our work. Unfortunately, the current lifestyle of working in the IT industry has stopped that pattern of sleeping. So people are actually working when they're supposed to be sleeping at night. So some of the risk factors for obstructive sleep apnea are morbid obesity, and especially a neck size of more than 17 inches for either men or women. Anatomical disproportion, it's a small jaw or a micrognathia, the large tongue. Men more than 40 years of age, postmenopausal women, family history of sleep apnea, smoking and alcohol use, and abnormalities in the structure of the upper airways. You see here, there's no other specification for women but postmenopausal women. And now a lot of gender disparity is being paid attention to because of the commoner problems in women. What are the signs and symptoms? There's airway occlusion, and there is a lightened depth of sleep and an easy arousal from sleep. There are repetitive bouts of low oxygenation. There is a heightened peripheral vascular constriction, also leading to hypertension. And those who are hypertensive have probably got resistant hypertension and fail to respond to medications. There are tachycardia and bradycardia events during sleep. Daytime symptoms on getting up are a morning headache, poor memory, and irritability. High blood pressure and other cardiovascular complications, and a feeling of depression and not having been rested or slept well at night. There could also be reflux, nocturia, and impotence. So these are the issues we need to look at collectively rather than just one sleep apnea syndrome. So we need to ask men about erectile dysfunction. We need to ask about a questionnaire on depression to see how they're feeling. So why OSA in a day program? Because it is independently associated with insulin resistance. And these are our cells, which are actually an endocrine organ by itself. And they also secrete a number of adipokines. They involved in the regulation role of insulin, both sensitivity and resistance, and the immunologically active cells, as well as the inflammatory process. Now we know that both cardiac disease and diabetes are on a common soil ground of inflammatory process. So that is why the inert adipocyte, though it looks inert, is actually very active in metabolism. And the adipokines secreted are leptins, which are pro-inflammatory, and the useful adiponectin, which is anti-inflammatory. And these are the two we are going to look at. This is where the leptin lies when we are measuring the abdominal girth at the at the umbilicus, or at the narrowest point between at the waist. We know that in men it should be less than 90, and in women less than 80 centimeters. So what do these adipocytes do? Actually, obesity itself is a pro-inflammatory process, and we are struggling with dealing with obesity. We do have thin fat Indians wherein all the obesity lies in the abdominal area. Obesity again stimulates leptin, which again stimulates the increasing inflammatory markers like TNF and interleukin 6, and going on to perpetuate obesity as a pro-inflammatory state. It has got an increase in the activated macrophages, and it is an increase in pro-inflammatory cytokines. And as Dr. Debashish also said, increased free fatty acids, both in smoking as well as in the metabolic state, all leading to a worsening of type 2 diabetes, fatty liver, asthma, and the metabolic syndrome. So like I said earlier, obesity is self-perpetuating, and the more we give in to these, the current availability of food, at the click of a button, you can get food delivered to your place. In fact, 90% of my patients on a survey were found to be sleeping at least 2 hours later than they were sleeping earlier. So which was earlier 10 o'clock has now gone up by 2 hours, and those sleeping at 11 are actually sleeping the next day. So insulin resistance is a feature of obesity, and it inhibits growth hormone. It also is inhibited. The growth hormone is even inhibited by the obstructive sleep apnea. It increases insulin resistance, and it is a worsening vicious cycle. Insulin resistance leading to increased triglyceride and free fatty acids and a pro-inflammatory state. So insulin and obesity are linked directly, and we often tell people that if you have diabetes in the family, ensure that the children get adequate exercise and they eat healthy so that you can reduce the pro-inflammatory state. So we're looking at insulin sensitivity and the metabolic syndrome. We look at central obesity, which is particularly in the abdominal area, both in men and women, increasing insulin resistance, lot of lipid abnormalities. Among them, the commonest one is having a high LDL, a low HDL, and high triglyceride levels, hypertension worsened by obstructive sleep apnea. The usual suspects, of course, are the insulin growth factor 1, the somatostatin, and the leptins, which again, as we diagnose metabolic syndrome, we are always in a dilemma because there are so many classifications. But the one most important factor that all of us check are the waist circumference, and which actually tells us clinically about the adiposity in the abdominal area. So insulin growth factor, of course, protein hormone, similar to insulin, and it helps cell growth. It also inhibits apoptosis or cell death. We are looking at the IGF-1 deficiency, where we have decreased peripheral utilization of glucose, increased insulin resistance, again hepatic neoglucogenesis leading to more fasting high sugars in the morning, and increased adipose uptake, and central adiposity, which is the bane of all treating diabetologists. We're looking at changes in the human growth hormone, and as we saw, that leptin secreted by our adipocytes has got an increased adiposity tendency. It downregulates the T regulator cells. It increases the reactive oxygen species and also increases the TGF beta. And these, all of them, result in increasing levels of altered genomics and diabetes. This slide a little difficult to see, but as you can see, altered gene and protein expression leads to insulin resistance, beta cell dysfunction, and type 2 diabetes. The two main causes of type 2 diabetes, all of us know, is either a reduced insulin secretion from the beta cells, which is due to beta cell dysfunction, and of course, insulin resistance or insulin resistance. So either of the two or both together leading to type 2 diabetes. And there are other risk factors too, aging and dietary excesses. These we all are aware of. So these are the telomeres, which are also affected in our eating habits and in the obstructive sleep apnea. And you can see the respiratory disturbance index is higher when the telomere length is reduced. So what does this have to do with sleep apnea? We looked at obesity and obstructive sleep apnea, and obesity, of course, is the central obesity with increased abdominal fat and increased waist circumference. Chest wall fat is increased, and there is a reduced lung volume. All this leads to obstructive sleep apnea, hypoxemia, and cardiovascular abnormalities. With obesity, there is also pharyngeal and submental fat, and there is an upper airway obstruction and collapsibility. With the result, the person has bouts of sleep apnea during the night and struggles to wake up and get the oxygen in, and there is the snoring sound is caused by the loosening of the airways, and a person has got sleep apnea, more so in diabetic patients because of diabetes being associated with obesity. This slide I have shown earlier, and there is also inducible cell death increased in patients with OSA. So having seen this, it inhibits the growth hormone. There is nitrous oxide production, endothelial dysfunction, dyslipoproteinemia, central obesity, insulin resistance, giving rise to atherosclerosis. So what we're trying to say is obstructive sleep apnea, if not corrected, would lead to atherosclerosis eventually and cardiovascular problems. So here we see the obstructive sleep apnea and the insulin resistance with impaired glucose metabolism. And you see these apnea hyperpnea index ideally should be less than 5. But here, as obstructive sleep apnea rises and the AHI index rises up to 30, what you get is more and more impaired glucose tolerance. So if you have patients who are not responding to treatment and are also complaining of snoring and poor sleep and disorders of sleep, maybe if you address that problem, you could get down the impaired glucose metabolism into range. So treatment does make a difference. And what we do is send them for sleep studies, find out what is their apnea hyperpnea index. If it is more than 5, it needs to be addressed. And we could do a continuous positive airway pressure or a positive airway pressure. And CPAP in diabetes, or continuous pressure, continuous positive airway pressure, causes an increase in the IGF-1, increases the growth hormone, reduces ghrelin and leptin, which are linked with increasing adiposity issues, and it normalizes the circadian counter, which I talked about, and the regulatory hormones. All these, when addressed by treating your patients with corrective action, whether there are medicines to treat sleep apnea syndrome, not really. Lifestyle measures are the way to go. Reducing weight, reducing your eating habits, sleeping in time, and making arrangements to sleep for an adequate 7 to 8 hours. So what we need to focus on is to reduce the risk of metabolic syndrome, asthma, reflux syndrome, usually associated with central obesity, and also to reduce rising pressures so we can reduce the blood pressure issues also in patients who are obese and having obstructive sleep apnea. Now, the homeostatic metabolic assessment, or HOMA, where we will, which is associated with an AHI index of more than 5, a low oxygenation, and the time in which the the oxygenation is less than 90%. These markers actually were independent of BMI, age, gender, smoking, and even alcohol consumption. So we need to reduce these issues of sleep. Glucose intolerance, total sleep time we need should be less than 7 to 8 hours when your patients are having OSA. So we need to look at that. Sleep fragmentation history needs to be taken, and a decreased or an absence of REM sleep. Of course, we know that there are 5 stages in sleep, where we have stage 1, 2, 3, and 4 of non-rapid eye movement sleep. And then we have the 5th stage of REM, which is the deep sleep. So we need to ensure that our patients are getting 2 hours of non-REM sleep, and then the rest of the hours they are getting the deep sleep. Thank you so much. And I think I have completed in time to let questions be asked.
Thank you, madam. Thanks for a very interesting. So we'll wait for some time for the question answer. Let's check me whether there are any questions there or not. Sir, are you here? Sir, are you here?
Chat box কিছু নেই বল chat box
No, chat box
চাটা নিয়ে আসছে চা বসিয়েছি বন্ধুরা এসছে দিদি সংসারের কাজ করছি দিদি জয় মা শুভ বিজয় দিদি
ম্যাডাম এতক্ষণ বলছিলেন যে আমরা স্পিকারকে দেখতে পাচ্ছি না।
হ্যাঁ, এখন আপনি এসেছেন। We couldn't see you.
Oh, আচ্ছা, I thought, আচ্ছা, but Niloy told me যে আমি তোমাকে দেখাবো নাকি, he said something.
না মানে আপনি আপনার ক্যামেরাটা অন না করলে আমরা দেখতে পাবো না।
আচ্ছা, তুই বলে তখন কিছুটা বলেছিস যেটা আমি মাথায় এই আর কি।
Good program.
How is uncle Didi? Yeah, good program.
Dada is fine, thank you.
আমি Nilay was telling me যে আমি হলো ওএসএ, আমি ওএসএ না নিকোটিন কোনটা বলবো? হ্যাঁ বল।
ওটাই বলছি, স্যার ওয়াজ টেলিং দ্যাট মাই টপিক শুড বি ওএসএ।
আমি অ্যাকচুয়ালি Nilay, you know that না যে ফিলিপস এর ওইটা আমি করতাম।
Right.
And sir, yes. And sir, OSA and diabetes, both the topic, they require a lot of awareness.
Right.
We also like nicotine and diabetes. We had one program. We also had OSA and a workshop on OSA and diabetes also 5-6 years back, where I think Transcend, ResMed and Philips, they all contributed.
Yes, they were there.
And then I was doing the rounds with Philips as a kind of contract killer, killing OSA. Jai Ma. No, খুব ভালো. And thank you, Didi, for coming in today and taking over, because this is good thing.
And next time, what are you planning for PQ?
PQ.
PQ.
আমাদের আজকে হলো MOOPQ. হ্যাঁ just
NO
হলো, হ্যাঁ PQ just as report দেখেছি।
NO. Share your thoughts, ma'am. You can give some ideas.
P.
So for P, you can also give some ideas, ma'am.
P তে কি যাবে? That positive attitude in diabetes patients.
Okay.
Because if they have that resistance to treatment and advice, very difficult to treat them. So
Okay.
positive attitude goes a long way in treating diabetes.
Yes.
Positive. Q.
So that we can take it up. Q.
Maybe you'll have to take a consensus from the team.
Yeah, sure. So that one idea we can share, and we will take ideas from others also. Let me check the chat box whether there is any questions. Okay, ma'am, there is a question for you. The question is OSA occurring only for diabetic patient? The question is asked by Mahfooza Muni from Bangladesh.
No. It is common in diabetic patients because of their associated obesity and central obesity, but just obese patients with other issues in the upper airways also suffer from snoring and OSA. So it's not specific to diabetic patients.
Okay. Another question is that what is submental fat?
Submental fat is the omental fat that you find in the obese patients, and it is huge amounts. And this is what the beauty industry tries to take advantage of, and they do the liposuction and remove just the omental and submental fat there, which is of really no value because it always returns.
Yeah.
So that omental fat that is present is what is present in the abdominal obesity.
There is something I might just add, if you allow me, Didi.
Yes,
Sure.
You know, there is this bidirectional nature we have seen, as we see, the ever burgeoning population of, obese and obesity and diabetes put together as a kind of a twin relationship. There is also this, element of diabetic neuropathy, and it is, of course, and in neuropathy that we always talk about is peripheral. But there is also this, kind of the autonomic component, which we tend to ignore. And they might actually affect the central control of respiration, somehow the diaphragmatic excursion, the upper airway, neural reflexes. Then that causes a good amount of, the RD, what we say, AHI and the RDA is the sleep disordered breathing. So that is also something which goes hand in hand. And there are a lot of accumulating data as we are working more on type 1 and gestational. We see even gestational as your pregnancy is giving you you're putting on weight and your diaphragm is getting higher and higher. That also affects your sleeping pattern. So that also has some relationship with the glucose metabolism dysregulation. So this is something that I wanted to add.
Sure. Thank you.
Joanna.
Thank you.
Mm-hmm.
Sir, we'll wait for another 5 minutes.
Continuation.
Okay, ma'am. I think we are done. So we are going to end our session. So thank you very much. Thanks for your lovely topic and lovely presentation, and thank you very much. And thank you, sir, for nice topic. So I wish you a very good evening, and we are going to end the session. Thank you very much. Bye bye.
Thank you, Mr. Niloy.